Welcome to our webinar, Creating a Pathway Forward from COVID-19, a Pragmatic Approach to Clinical Care and Personal Health. I'm Judy Thompson, Director of Education at the Association for Vascular Access. And now it's my distinct pleasure to introduce our speaker today. Dr. Hudson Garrett is a nationally certified emergency medical technician and COVID response team member with ProCare Emergency Services in Atlanta, Georgia. He has a faculty appointment as an adjunct assistant professor of medicine in the Division of Infectious Disease at the University of Louisville School of Medicine. He also co-founded the nonprofit Infection Prevention Institute to help shepherd dissemination of best practice of infection prevention and control across the healthcare continuum of care globally. He holds a graduate certificate in infection prevention and infection control. He has completed the Johns Hopkins Fellows Program in Hospital Epidemiology and Infection Control. Dr. Garrett serves as the Public Safety Liaison for the Greater Atlanta chapter of the Association of Professionals in Infection Control and Epidemiology. He is also a certified tactical medic and holds national certifications as an advanced emergency medical dispatcher, certified fire dispatcher, public safety telecommunicator, and Communications Training Officer from the APCO. He has additionally graduated from the Barrier Precautions and Controls for Highly Infectious Diseases course operated by the Federal Emergency Management Agency Center for Domestic Preparedness. He is board certified in vascular access, critical care, infection prevention and control, and patient safety. With that, Hudson, please take it away.
Thanks, Judy. Since we're doing CEs, here are my disclosures in the interest of transparency. And getting right into the objectives. So we've had several of these programs over the last 2 months. And really the objective of what Judy and I wanted to accomplish today was to look at sort of where are we going next, and particularly through the end of 2020 and into the future. So that's really the focus of this, is to look at those future implications to our overall healthcare system. We're also going to talk about some of the new and exciting diagnostics and therapeutics coming out. And then we'll finish with setting up a little bit about what you can do to protect your families as well. As Judy mentioned, we've got the sort of Family and Friends program on Wednesday, which we're excited about. This is not something AVA's done before. So if you have any, of your friends, family, loved ones that are looking at sort of a layperson version of this, that's the right program for them. As always, we want you to refer to the CDC website, which has got the most up-to-date information. This presentation has got a lot more data than we've ever had before, and I want to show you some various sources that you can pull from to understand what the potential impact in the future will be, and then how can we prepare for that a little bit more effectively than what we've done before. I wanted to start with a little bit of a difficult subject, which is that this pandemic is having tremendous mental health impacts on our profession, many of which have not been fully appreciated and will not be fully appreciated for quite a period of time. Having known someone who has had COVID, that has, contemplated some mental health challenges, as well as knowing several coworkers that have actually contracted COVID infection and have had health consequences from this, this is something that's really personal. We recognize that stress alone is bad if it's not properly managed. And so this pandemic is causing a little bit of a wave of PTSD with many healthcare providers, and rightfully so. From everything from PPE to sort of the difficulty sleeping, not being able to work your normal hours, and in many cases, not even being able to work in your normal practice environment. I was reading a pretty interesting thing last night about an ambulatory surgery nurse, and her whole team was pulled in to work in the ICU, and she's not worked at the bedside in an ICU setting for 20 years. And they gave her a 3-hour course, expecting her to be safe in her practice. And of course, that's not something that we can do safely. So there's a lot of learnings that come from this. And then lastly is sort of that exasperation of other health problems that we might have, and some of the unhealthy behaviors that might come from that. So I'd like to think about what does that new normal look like? And the answer is we don't know. I think we're going to hopefully land somewhere in the middle of the sweet spot and determine, this is what we need to keep. These are things that were very specific to this pandemic, and here's some processes that we might want to change. So, for example, I think we can all agree that, COVID is here, and it's probably going to be around for quite a period of time. what that looks like as far as the number of new cases, hospitalizations, and deaths is all up in the air. And I'm going to show you some really exciting sources of information and detail that are available to you that you can pull in real time that will help us manage our staffing, look at our supplies such as our PPE, and understand when our services as vascular access professionals might be most needed. I also want to recognize that there's a lot of creativity going on. What I love about this sort of top left picture here is that you notice that these clinicians have done something very simple but very amazing by introducing themselves with their picture and what their role is to the patient and sticking that on their PPE. This is something that I've started doing lately, and I really think it brings to life that connection that the patients really expect to have with us. We've seen a lot of resilience. We've seen a lot of empowerment. We've seen clinicians that have stepped across traditional boundaries of care and are truly trying to deliver upon the promise to keep the patient safe. And that can be very difficult as we work through this. Many facilities, and I'm going to make a little bit of a controversial statement here, have put healthcare workers in a difficult position. And while you see the sign says heroes work here, sometimes your actions are not congruent with what the sign says. And a particular example of this is asking clinicians to work in settings without the proper PPE or tell them that they can't bring their own PPE in. And this was a question that came up pretty hugely on the last webinar that Judy and I did about what do I do if my hospital won't provide the PPE and I can bring my own in? And in reality, as a healthcare leader or administrator, whatever their role may be, they own the safety of their clinicians and the safety of their patients. And we must take all necessary steps to safely deliver care for our patients. And so if you don't have the right personal protective equipment, then you cannot care for that patient. And I go back to sort of our colleagues that work in public safety. You're not going to see a firefighter run into a fire without a breathing apparatus. You're not going to see an ambulance roll down the street without oxygen on board or the medications that are needed. And we're not going to see surgical, cases take place if we don't have anesthesia. So why should we, potentially deliver vascular access care without the appropriate PPE? So that's just something to put in perspective. As we talked about before, there's been new updates with the federal response. One as recently as last night, and that's the availability of antigen testing to look not only at the presence of infection today, but also the previous presence of infection and potential immunity. And we'll go through that here in detail in a second. And there's been an exponential increase in the public-private partnership around PPE therapeutics. The vaccine development is going extremely quickly. And one of the biggest things that I think has happened since our last webinar is this sort of multinational crackdown on fraudulent personal protective equipment to the point where the FDA has criminally gone after many people that are gouging hospitals and healthcare facilities with inappropriate PPE that's never been regulated, is certainly not efficacious. And a lot of the PPE that is coming from China through legitimate sources has been determined to not be as effective as our normal PPE. And so I've provided a web link here in a few slides where you can go and view the products that have been deemed not effective to ensure that you do not have these in your facility. Now, you may say, well, I hope my facility is also checking that list, and they should be. But in reality, I want to make sure you can drive your own destiny by giving you the tools to find this information yourself and protect your department and colleagues. So I'd like to transition into some newly available data that will paint a very statistical picture of where we are and where we expect to go. So the first thing is let's look at the total number of cases that we have. And this was run last evening around midnight, and we're a little bit over 4 million cases. Again, I want to provide the preface that the number of cases going up is going to continue. As we continue to do more and more testing, we will see more and more positive results. What I look for is sort of the recovery and the hospitalizations. So, for example, if I have a market increase in the number of cases, but I'm seeing a very standardized decrease in hospitalizations, deaths, and an increase in recoveries, then that's a good thing. But if I'm seeing sort of an exponential increase in all of those factors, then I know that I'm not going in the right direction. If we drill down a little bit more into this, into the U.S. data, not only can you look at this by county and state, but you can now look at this by social outing, which I'm going to show you here in a second. So as we look at the effectiveness or non-effectiveness, if you want to battle both ways, of social distancing, we recognize that there are certain hotspots, and these hotspots are typically tied back to sort of a congregation of people. And what's interesting is that when you look at the CDC reports and data, there are not widespread reports of healthcare workers that are appropriately using PPE being infected. Where we're seeing healthcare workers being affected is traditionally when you have people that are not appropriately using PPE or they're not provided it at all. Or community transmission is actually the largest pot of that pie. So if we want to know the true answer is the curve flattening, you can see the data here, and we're currently obviously at the very beginning of May. And so you can see that there is sort of this wiggle wom going back and forth that almost looks like a bad EKG. And so we recognize that the numbers in general are up, and so we're not seeing a nationalized flattening of the curve. But again, if we're looking at total number of confirmed cases, this does not determine if these people are actually going to be receiving healthcare services from us. So it's very possible that many of these people may not have symptoms at all, may never present symptoms, may never seek healthcare services, or they may be folks that do. And so it's really important to look at the total picture. So when we look at the last 7 days by state, you can see that those that have a darker, like California and Texas, are examples here. They have a sort of a large amount of new cases by jurisdiction. But when you look at the data I'm about to show, you'll see that the U.S. is statistically doing much more testing than any other country. So again, the total number of tests do not indicate that these are people that are in our healthcare systems. And prior to just a few weeks ago, it was really impossible unless you had access to certain internal data with CDC to determine sort of how prepared are we as a country and how prepared are our hospitals to sort of absorb a future wave of COVID-19 or other potentially infectious things. And this graph is actually one of my favorites. And this is social outings that caused outbreaks of COVID-19 infection. And so if you see the really dark ones that almost look brown, these are 5+ events that were identified here. And this is where this whole concept of contact tracing comes in. Contact tracing is really the ability to follow back where that initial infection started all the way through the people that might be potentially impacted by that contact. One of the unfortunate examples we're seeing right now is the director of the CDC, the head of the FDA, and Dr. Fauci from NIH are all under some form of quarantine because they were exposed within the White House. And so this contract tracer could potentially include their families and other people that they may have come in contact with as well. Judy, do you want to go ahead and throw up the first poll? So our first question is do your facilities have enough PPE for all of the clinical staff that need it? So I just want to preface this before you answer. We're talking about the people that literally need the PPE because they're performing some type of clinical function of high risk. So let's see what the responses are for this. 21% no and 24% unsure. So if you're in the unsure category, I would recommend that you talk to your infection preventionist to determine, hey, are we actually sort of allocating these to the right people and who those folks are? If you're a vascular access person and you're going into a room with a COVID patient, then certainly you would be qualifying for this. Respiratory therapy is another high-risk area as well. Really, the patient care techs are at high risk as well because of the number of sort of clinical care procedures they perform, like bathing the patient, changing linen. So they're going to have a lot of contact also. So the next slide is really looking at something new. And if you're a parent, you understand where I'm coming from on this. And it's looking at school closures. And so when we look at school closures, there's long-term and short-term impacts of this. For example, if you reopen a school, and if you've got kids going back to school, you're probably very anxious for them too, because you don't want to continue to serve as the teacher as well. There may have faculty members that are in that high-risk category, being over 65 or have chronic health conditions. And so, this is problematic in general terms, but it also impacts the resiliency of the healthcare workforce. This next slide is something that's new as well, and I think is hugely important. When you look at this data, you're going to see the total number of tests reported. So we're, in upwards of 8 million. And out of that, the positive tests are about 1.3. So if you look at sort of the overall positive test result in the United States, it's about 16%. This is very similar to what they found in New York City, which was around 25%. So again, if you're a person that is in that 16%, that doesn't necessarily mean that you're going to ever have any long-term or even short-term health consequences from this. And that's certainly our hope, is that you don't. But if you're one of those folks that does have comorbidities, then recognize that as we see more tests and more positive patients, that will increase our number of hospitalizations. And that's something that we want to think about as well. So this is a new piece of data that's available from what they refer to as COVIDNet. It's a part of the CDC data system. All of the web links that I put on the bottom of the data today, you can actually click and drill down into your own local geographies as well. So none of the information that I'm sharing with you today you can't find on your own. But you can see the number of hospitalizations. And I want to particularly call out the pediatric population because we've seen an increase in sort of the systemic inflammatory process that's been particularly seen in the New York City area, where patients are presenting sometimes with COVID diagnoses, but they have this sort of massive inflammation process that's, affecting their D-dimers, their SED rates, their CRPs, and the like. But you can also see the breakdown of hospitalizations for 65 and older, which is evidenced by that top line. So again, the patients that are at the most risk for hospitalization and subsequent mortality and morbidity are those in that category. So just something to think about. A new resource, which I think is incredible, is to be able to look at the number of inpatient beds that are occupied versus ICU beds. Some states can actually get this down to the ER as well. And you can determine, hey, in this particular geography, do we have enough open beds? Should we have another wave? And if you're, well into sort of the, 0 to 20% of occupancy, you've got plenty of room. But if you're in the 71% or more, then, these geographies might have to have some type of other stage reopening. And this certainly applies to hospitals as well. If you're in an area where you're seeing 80 to 85% of your beds occupy still, it probably doesn't make a lot of sense to resume elective procedures. Because you don't necessarily have the inpatient capacity to care for patients should you need that. And then lastly, there's a new graphic here that looks at death certificates that list pneumonia, influenza, and COVID-19. And you may say, well, I don't really care about pneumonia and influenza right now. Well, you will, because as we move and transition into the fall and winter period, these other respiratory infectious illnesses are going to be extremely important. And so, the cause of death being listed is a very politically charged situation. I've heard everything from, hospitals were told to do it because they get more money to the government told them. And, the truth always lies somewhere in between. But in reality, when we look at death rates, it is important for us to determine what was that primary cause of death so that we can understand what the sort of pathogen is doing to the body and what its actual impacts are. So if I have someone who, for example, has COPD, CHF, diabetic, hypertensive, and they get COVID, did they die from the COVID infection or did they die from one of their comorbidities, or was it a combination of both? And sometimes that can be very, very difficult to determine. But this data is updated. It's about a week and a half behind normally, but it's a really important thing to look at, especially as you're preparing for future waves that might come in. And if you break it down further by age group, you again will see, people that are above 85 are at the highest risk. And then again, 65 to essentially 84 is high risk as well. And you see a higher mortality or hospitalization, should I say, in that 0 to 4 age range than you do the 5 to 17. And again, as we see more children get tested, it'll be very interesting to see what sort of the mortality and morbidity looks like in kids, especially with this inflammatory disease that is sort of new to us. There is data tracking that's taking place through the National Healthcare Safety Network. So if you're in a hospital environment, you're already reporting to this. If you don't have access to this information, you can always talk to your infection preventionist, and they can certainly help you out with that. But there is a new COVID-19 module that looks at reporting of both the sort of patient and impact to the hospital capacity, right? So do we have enough beds? Do we have enough ICU beds? Do we have enough healthcare supplies through the form of PPE or ventilators? Do we have enough gloves? For a short period of time, there was actually a shortage of normal saline, which didn't make national news, but many regionalities actually had trouble getting saline. And we've been through this before, and I can't imagine something more fundamental to vascular access than normal saline. And then lastly is, do we have the right people that can work? So, for example, would it make sense to take a surgery nurse and put them on the vascular access service? Absolutely not. Would it make sense for you to take an ER nurse and have them come help out on vascular access? Potentially, right? They could certainly do the peripherals, they could do dressing changes, but maybe they're not qualified to insert a PIC, as an example. So having that diversity in the healthcare workforce is something that, as we look forward, we need to have as much cross-training as possible, so that as we, get retooled and sort of shifted around, if you will, we have access to the skills and training that are necessary. So let's transition now from what we know about the infection into sort of the clinical presentation updates. And in my first webinar I put up this slide of sort of that traditional fever, cough, and shortness of breath. And then we talked about that sort of morphing into these other symptoms. And just in the last 2 weeks, CDC has updated this again to look at things like new loss of taste or smell, certainly the asymptomatic people. And now we need to think about our pediatric populations. So if you're in a facility that treats kids or you're a pediatric facility, you certainly understand what I'm talking about here. But that incubation period and the presentation of symptoms can be different from adults to kids. We also want to recognize that many of these folks may be asymptomatic. So I'm going to share with you a little bit of a soapbox. But I go into hospitals pretty frequently with my other job that I work with, and all too often we are screened, and it's typically in the form of a temperature check. And in the best places, they do ask us a few questions. And having been exposed to well over 200 COVID patients now, I always answer the question, yes, I've been exposed to COVID. No, I don't have any symptoms. No, I don't have any relevant travel history, et cetera. And I'm just shocked that no one asks me any more questions when I say, yes, I've been exposed to a known COVID patient. Because we need to ask questions, but have something behind the question that says, if someone answers this way, this is what we're going to do. So, for example, a reasonable accommodation may be you can't come into the facility if you have a fever, or if you have no symptoms but you've been exposed, you need to make sure you wear at least a mask. So those are all common things that we need to think through. The pediatric presentation, which is very interesting to me, is primarily like cold-like symptoms. And so this is very difficult to discern, especially in a pediatrician's office where you have kids that get colds and flus and all kinds of stuff every day of the week. And so we probably would see more point-of-care testing in this pediatric population. It'll be interesting to see what the antibodies look like for an adult versus a child, and what does that really mean, and we'll talk about that here in a second. But as a parent, if you're a parent, this is something to be aware of, especially as you reintroduce kids to daycare and other community settings like the schools. Honestly, I have very little qualms about schools reopening with the right restrictions and the right attention to basic infection control measures. And these are all things that we should be doing all the time, not just with COVID-19 infection. So if you watched the news last night, I took a snapshot of the TV here, but this was what the mayor of New York was talking about. And these, again, are sort of this novel concept associated with almost like this massive sepsis, if you will, that's inflammatory in nature. And so roughly 50% of these kids were positive for COVID-19. And so, these are folks that are having issues with clotting factors, respiratory issues, but it really looks like it's a sort of a multi-system inflammatory syndrome. And this is very concerning. We saw this many years ago with kids that were suddenly being paralyzed, as an example, related to a virus. And so it's not new in the sense that we haven't seen something like this before, but it is certainly being tied very closely back to COVID-19 infection or exposure. So this is something to think about from a pediatric standpoint. The case fatality, the latest data that came out on Friday of last week was around 1.5% as sort of the highest. It can certainly be higher than that as you look at the different data sets associated with that. But again, anybody, including us, that has comorbidities is going to increase that risk. So one of the big questions I'm often asked is, I'm a healthcare worker and I have COPD, or I have asthma, or I'm diabetic. Is it safe for me to go back to work? And the answer is yes, it is. As long as you're wearing the appropriate PPE and you're maintaining your own health, I really don't have any issues at all recommending that for anyone. There will be certain circumstances where it may not make sense. For example, if you are somebody with coronary artery disease and COPD and the facility can't fit test you for an N95, or the masks don't fit, and they have no alternative, then no, it wouldn't be recommended for you to go back into a clinical care setting until they can rectify that. So never sacrifice our personal safety for what we're given as far as PPE. recognizing that hospitalizations in most places are starting to trend downward, which is a good thing. Even in New York City, last night they had their lowest death rate, which, anything above zero is bad, but we're trending in the right direction. How do we make sure it's sort of maintained that way? And when we look at sort of these acute respiratory distress syndromes, what's interesting is that from the time we did our last webinar to today, there's been a really big switch and a positive switch in putting patients on ventilators as sort of that last line of defense. So if you look at the Society for Critical Care Medicine, they put out exceptional guidelines about sort of guiding the respiratory therapy, antibiotic therapy, antiviral therapy, ensuring the patient has vascular access, they're cared for in the right setting. These are all important elements as we care for these patients that do require that more advanced therapy that we can offer. And as far as transmission, this is probably one of the biggest things that has confused people. Just last night, I was coming home from actually running an errand to the grocery store, and I was just astounded at how many people are driving in their car alone with the mask on and gloves. And then they get out and they wear the same gloves into the grocery store or to the gas station or whatever it may be. And so this person-to-person transmission is, again, that primary route of transmission. But there could potentially be other sources like your inanimate objects like gas pumps and stuff like that. My recommendation is not to wear gloves everywhere. Gloves can provide a whole host of other issues associated with them, especially when they're improperly used. They can contaminate other things as well. So I'm a big proponent of recommending hand hygiene. And then when we have community spread, this is something that we as healthcare consumers need to think about in the future. So as I think about what activities do I feel safe resuming? Do I want to go to a movie theater? Do I want to go to my doctor's office for my physical? Do I go to the emergency room if I have a true medical emergency? I feel very comfortable doing certain things based on community spread data in my own jurisdiction, which is Atlanta, and I feel uncomfortable doing other things. And when I go to emergency departments around the Atlanta area, they're dead. They are very, very, low census, and that tells you that we still have a big problem. Even if it's not data-driven, it could be perception-driven. And what's going to be very concerning to us as healthcare providers is the patients we're going to start to see when this calms down a little bit that have had, MIs in the past, or they had strokes and they had a TIA first and they didn't seek treatment, or they've got something else chronically going on that needs a surgical intervention, and they just simply did not feel comfortable coming to see us. And so we as healthcare professionals have a long way to go to sort of regain the community's trust in this. And part of that starts with documenting where community spread is, ensuring that we're going to have sort of a balanced approach to this. If I've got a kid playing in the front yard, it probably doesn't make sense for the police to come out as an example. We've seen this on the news time and time again if they're not interacting with other people. People are stir crazy. I totally get that. I am as well. And that's really where this staged reopening guidelines come into play. And a lot of that's going to be driven at the state level based on sort of the relevant data in that jurisdiction. But hospitals also have to look at this and say, what do we need to do from a staffing perspective? Do we have enough PPE? What about when these antiviral therapies come out? How are we going to make sure we have an allocation of that to care for any patients that we might have? And, part of this is good and part of this is bad in the sense that, I love this quote that history tells us that an informed, activated population is vital protecting the public's health. So it's only as helpful as that activated population is properly informed by true public health measures that actually are rooted in evidence. So, wearing a mask in your car alone doesn't make any sense in the world. But wearing a mask if you're going to go into the grocery store or somewhere else where there'll be potential close contact or contact with environmental surfaces, that makes all the sense in the world. And so it's really hard for the public to sort of figure out how to apply some of this guidance that's out there. And if you're one of those people or know those patients that had these at-risk populations, then this is something that we need to think about carefully. One of the worst affected areas is long-term care. We've seen this as evidenced in New York State, where there's over 5,000 deaths from long-term care, which is just astounding. Having been in long-term care facilities here in the last few months, I am literally shocked at some of the practices I've seen. The first week that the social distancing was impacted or enacted, should I say, federally, I walked into a long-term care facility to get a patient with COVID, and there were over 150 residents all congregated in the community area in wheelchairs within a foot of each other, simply so that the nurses could watch them. And again, we need to be pragmatic and really think forward thinking about this, because we may see a decrease in community spread, but we may see an increase in some of these vulnerable populations, like our long-term care facilities. And these are people that absolutely deserve our utmost best care that we have as well. And we've already discussed that emerging evidence of that multi-system inflammatory process taking place in kids. What I'm interested in with that is, how long does it last? Is it sort of an acute, or is it a chronic condition? Are there any serious health effects that come from that? And how does the patient respond to any type of treatment? Is it an inflammatory process we need to treat similar to SIRS or sepsis? These are all things that we have to think through and document carefully. And we recognize that there are, again, evolving approaches to infection control that, go from everything from minimizing your exposure all the way down through environmental infection control and the like. So the screening recommendations, we've talked about this before, but I want to take it a little bit of a step further. If you're in a healthcare setting working, for example, then you're probably being screened. That screening does not look like this. Have you had any symptoms? No, right? That's not screening, right? That's something that we need to take very, very seriously. So we need to ask the questions. We need to help the staff understand how important this is, and also look at that exposure history. I'm actually less worried about exposure history while at work as I am about people outside of the work environment, because hopefully, at least in the hospital setting, you are somewhat having a controlled exposure through the use of PPE. One of the best ways that we can stop transmission is to make sure our patients are masked. Certainly that's very uncomfortable for them, and doesn't have to happen, the whole time they're hospitalized. But when we're coming in and out, or we're moving them from one area to another, or we're taking them down to interventional radiology, let's mask them. That's really going to be helpful, because then we have that source control on both us as well as the patient. And when we get screening questions that are answered funny, like, yes, I was just exposed, don't just accept the answer, actually do something with that data. Is this something where this person has to not be able to deliver clinical care? Is this an exposure that took place at work? If it was, was it a controlled exposure, so that we don't have healthcare workers transmitting this throughout our healthcare environments? This is a great graphic that CDC put out that really looks at the preferred PPE versus the acceptable alternatives. One thing I'm going to talk about and show you a study here in just a second is the importance of covering our eyes and our face. I can't tell you how important this is. This is really, really important to cover the mucosal membranes there. So, having an N95 respirator or higher is certainly the best, but a face mask is also acceptable, especially if you're not doing aerosol-generating procedures. Now, would I tell you, if you have access to an N95, to not wear it? Of course not. Wear the highest level of protection as possible that you have been given. But if you don't have a face mask or a respirator, it is certainly not safe to enter that patient's room. And so that's an example of where we're going to start to see, risk and risk management get involved in things like that. And one of the other questions related to PPE that I'm often asked is, should I just invest in a coverall? And the answer is, those have advantages and disadvantages. If you're working in a long-term care setting and you're only working in the COVID area, where they've got these patients segregated, then yes, it makes total sense to wear a coverall. You're going to decrease your use of gowns. These are already patients that are infected, for example, and so that would be an acceptable alternative. But, gowns are only as good as they're tested. Many of the gowns that are being used in healthcare settings are not rated for isolation gowns. So a lot of this alternative PPE that's coming in from China, as an example, is not properly tested. And so you do want to understand what level protection from 1 to 4 is your gown. And if hopefully it can be impervious if you're doing any type of procedure that might result in a splash, but most of the gowns that we're using are not. The other thing is looking at minimization of PPE. I have seen some horrible, horrible things in the last 2 weeks related to misuse of PPE. I've seen just in the last weekend, I saw a staff member in an emergency department that was responsible for patient registration that was in a full coverall, a full face shield, an N95 respirator. She was also wearing goggles, and she literally had on 3 different pairs of gloves. There was no reason for that. And so that's a waste of PPE that needs to be coordinated with our clinical leaders to say who really needs PPE and then who needs to go into the room. I don't necessarily want to send a registration technician into a room with a COVID patient. That seems completely inappropriate. They're not trained for that. They probably haven't been fit tested. Why waste PPE on them? Maybe have the nurse go in and collect the information or the ID, whatever's needed, in order to ensure that PPE is used appropriately so that we can optimize the availability. Having talked to a hospital that had a major outbreak in the U.S., they went through their 6-month emergency supply of PPE in 7 days. And so understanding what your burn rate is and the number of patients you might receive in a surge is hugely, hugely important as we look at sort of future preparation. If you're a vascular access team leader, you need to, work with your materials management folks to say, hey, I have 15 people, 10 people, 5 people on my team. These are the hours of operation that we anticipate operating within. Here's our need clinically for PPE. Here's what comes in the kits as an example. And then you also might want to think about stockpiling some of the procedural kits because many of these have gone on back order as well. The University of Nebraska is by far probably one of the most knowledgeable areas in really the world related to infectious diseases. They are actually the country's designated quarantine facility, and they were also designated to take care of Ebola patients as well. And so they've developed a series of posters for donning and doffing of PPE that I think are really simple, really helpful, and give an idea of what you need to do and in what order. And you'll notice that when you're taking things off, you're actually going to remove the stuff that's most contaminated first. And so this is something that's available. Judy's also been kind enough to upload the poster, the PDF version, to your handouts on the right side of the screen as well. So, Judy, why don't we go ahead and do a second poll real quick? Interesting. So about 50% say falling, 30% status quo, and about almost 30% rising. So it's good to see the green bar for sure as far as the falling rates. What we do want to see, though, is sort of a rise in the status quo moving into the falling category. So certainly when we look at this across different geographies, it can be interesting to see. And again, certain counties may be even different. And so as a hospital system, think about the catchment area that you serve and also think about your family and loved ones, because what we found with Ebola as an example is that there's an impact to the family of the healthcare workers as well. There was a beautiful tribute last night on American Idol. I just was flipping their channels and I saw that they opened the show with sort of little caveats and video clips from healthcare workers of all types. And one of them was, thanking their mother for allowing them or not being upset to see their own mother on Mother's Day. I'll tell you for myself, it was very difficult for me not to see my mom, but I've certainly been around too many COVID patients to expose her. And, it does take an impact on the family. As we look at face mask usage, I want to be very, very deliberate in what I'm about to say here, is that there are many, many sources of fraudulent PPE that are being brought into hospitals. And so FDA is taking this very seriously. They put out guidance that says these are items that we do think are effective, and these are items that we know are not. And so certainly if you receive PPE and it looks defective, it doesn't fit properly, the straps are broken, those types of things, don't use it. But there's a guidance document that I've linked there on the third bullet point that talks about the fraudulent COVID-19 medical products that are out there. There's also a web link that you can actually directly report these folks to the FDA if you were to receive fraudulent product as well. And there are some sources coming in from China that are legitimate, but there's not a ton of them. And so it's important to make sure that whatever you and your team are issued or you issue for your family, because many people have bought these KN95 masks for their family members. And you want to make sure that you're getting something that's a reasonable protection to protect your friends and loved ones. Aerosol-generating procedures, nothing has changed here. Other than I've had many, many questions about what the definition of that is. And certainly there is a link there at the bottom. And you can actually find the definition as per CDC of what they consider sort of straight out aerosol-generating procedures. I will tell you that I've seen many justifications. People that have said, I'm walking through the hall, there's aerosols, I need an N95 respirator. Well, it doesn't work that way. So we want to make sure we prioritize for the true need, like respiratory therapy, your emergency department, your intensive care setting, surgical procedures where there might be a reasonable suspicion of aerosol-generated risk, and then also ensure that you have negative pressure rooms. I've seen many, many hospitals that, of course, ran out of negative pressure rooms, and so they're just closing doors. Another good solution is to have a portable HEPA filtration system as well. These are all things that can particularly negatively impact you doing a vascular access procedure by having air that's moving around. So just consider that. And then, of course, we've got many of our normal practices that we do for vascular access procedures, like draping the patient, putting that mask on them for source control. If they've had the same mask as a patient since they were admitted 3 weeks ago, do you really think that mask is effective? Probably not. So it would make a lot of sense to ensure when we're moving patients or having, high-risk interactions with them, like inserting a PICC, that we do put that mask that's fresh on the patient for source control. A lot of hospitals are also using the sort of cloth, homemade mask. That's fine as well. Anything's going to help here. And if it's something that we can't do safely, we should cancel or postpone it. I did want to mention a little bit of a personal caveat about face shields. This data just came out on April 29th in the Journal of the American Medical Association, looking at face shield efficacy. And you'll notice where it says a simulation study of influenza virus found face shields reduce viral exposure by 96%, right? And so when you look at the effectiveness of just general safety glasses, goggles versus a face shield, I personally really like the face shield. Not to push it, but it's more comfortable for me. I get less fogging. I feel like I have more generalized protection over my mucosa. If you're wearing eyeglasses, you can wear those underneath. And so this is something that I would really think about. And many of these you can actually get are reusable, so they can be clean and disinfected. And there's also been some discussion that's come out of Johns Hopkins about even issuing these to members of the public, so that there's less transmission, because if you don't have enough mask, it's a lot easier to make some of these generic face masks, or face shields, should I say, than it is even a respirator-type mask. And as we look at environmental infection control, what you're doing at your home should be very similar to what you're doing in the healthcare environment. It should be an EPA-registered disinfectant. It should be one that's on the list for COVID-19 effectiveness. Remember, it's not going to have the name on there that says COVID-19, but that list is available on both the CDC web link there as well as the EPA's website. There are lots of products that have come into existence in the last 2 months that are completely illegal. And so EPA is aggressively going after these companies, and that is a federal crime to illegally market a misbranded product like that. So they're taking that stuff very, very seriously. But in general intents and purposes, this virus is super easy to kill on surfaces, so there's not a lot of risk there. And since we're in May, it is Hand Hygiene Month, which I have sort of mixed emotions about, because we shouldn't have Hand Hygiene Month. We should have hand hygiene all the time. And so these alcohol-based hand sanitizers are perfectly acceptable. What most places are finding is that they can't get enough of the gels. So a lot of facilities have gone to an 80% based alcohol, liquid, if you will, which is not very pleasant. Soap and water is absolutely acceptable, especially for patients that might have co-infections with like C. difficile or something like that. But all of the alcohol-based hand sanitizers that are out there are going to be very effective for use. And so when we think about our general practices of moving this pandemic forward and what that new normal is, that new normal always must include washing our hands when indicated. Again, I go back to a statement many years ago that colleagues at CDC told me. They said if we just washed our hands, about 80 to 90% of infections would go away. And that's an astounding statistic to think about and the relevance of that. But we really want to make sure we improve hand hygiene compliance. And part of that is really using PPE as that last line of defense and trying to eliminate the hazards. So a lot of hospitals have actually put up tents outside. Many hospitals have dedicated rooms for procedures that are negative pressure. Sometimes they don't let certain healthcare workers get around those patients. So if I've got somebody that's 65, close to retirement, with lots of medical conditions, then maybe I don't want to put that person in the clinical environment. Maybe I put them on phone triage or some other function that still allows them to use that clinical expertise, but in a low-risk environment. But we also don't want to have the flip side of that, which is let's put every young person in front of every COVID patient just because they're young. It doesn't work like that. We're all charged to do a job. We want to make sure we do it safely, uniformly, and with good equity there. This is actually a sort of a third-party website that looks at COVID tracking on a daily basis. And so if you look at the very bottom of this, we're looking at Friday, April 24th through last night. And we went from basically 5 million tests to almost 9 million tests. That's an astounding increase in the number of testing capabilities that are out there. So there's different types of testing, and I'm going to expand on what we talked about last time last time we talked about PCR, and I'm going to break this down here in a second, but just as of the last 3 days, there's a new antigen testing that is approved by the FDA as well. And this can be used for both sort of the monitoring of the patient, if it's a healthcare worker, to determine if they can come back to work, and specifically to look at antibodies. So let's sort of break this down a little bit further. A viral test is the one that we're most commonly seeing out in the community. And this is where that very uncomfortable nasopharyngeal swab or potentially a saliva test, which is new, is looking for active infection. So with this test, when we're looking at sort of this molecular test, we're looking to see, is there presence of active infection? And that could be either done with PCR technology or the new antigen test. Whereas the serology test is really looking at the presence of the antibodies. So was there a previous COVID-19 infection, and did they develop antibodies? Not everybody, of course, will, and it's really a determinant as to what potential immunity looks like. There are a lot of actors in this space. So if we look at the molecular breakdown, there's over 30 companies that have FDA authorization, emergency authorization. There's over 110 that are trying to get it. Right? So there's the nasal swab and the new saliva test, and the results can be less than an hour up to a few days. Absolutely moving forward, I think we're going to all basically only be doing the tests that are rapid. It gives us more capability. We can follow up with the patient instantaneously while they're still there. And the PCR, the advantage of that is that it looks at specifically the genetic sequence of the virus. So it's a little bit more sensitive. It's going to get more accurate results. The antigen test, for example, is looking at the presence of molecules on the surface of the virus. And so this is only going to be effective about 85% of the time at looking at those that actually have infection and saying that they do. But the delivery of that is very similar to other point-of-care tests like strep and flu and things like that. One caveat with this new antigen test, and this comes from the FDA, is that if I have a patient that elects to use that, which is fine, that's probably what's going to be available in doctors' offices especially. If I get a positive result, then you're going to want to still confirm that with a PCR molecular technology. So it's very, very similar to a rapid HIV screen. If that is positive, then they'll still send that for ELISA testing or some other type of PCR testing. The serological testing, there's sort of two different flavors that can happen here. You can have IgM, which is your recent exposure to COVID-19. So these are patients that are not going to have antibodies. And then there's IgG. And these are patients that typically will have some level of antibodies because they're in the latter stages of that infection. And those results can, again, be done at point-of-care testing in about 2 to 15 minutes. So a lot of different options here that will help us. To help educate patients and consumers, the Department of Health and Human Services has put out this guidance document that really says, what should I do if I have this test? So, for example, if you're somebody who's positive, then there's a high degree of suspicion that you do have the infection and you should self-isolate. So these are sort of the ways that you can interpret that information. As we look forward into where do we go in the future, one of the biggest challenges we have in front of us is what do we do if this hits again? Or what do we do if this hits in the middle of flu season, where we already have 80 to 100,000 people that are negatively impacted by this? We have to ensure that we have the right surge capacity. And so CDC's released this new estimate, which is called the COVID-19 surge. It's a spreadsheet-based tool that helps you sort of predict what are going to be the potential impacts in your community. How is it going to increase the demand for your hospital services? What are your catchment sizes, meaning your populations that you serve? And then what are your available resources? So if you have 20 ICU beds and you only have 10 ventilators, then do you really have 20 ICU beds? Because all of those patients may potentially need a ventilator. These are the things that it takes into account, and it's a great resource. And so I would encourage us as a vascular access specialty to do the same thing for things like our ultrasound devices, our kits that we have. How many of our staff members are going to be willing to come to work? Or some of them going to have to stay home due to childcare issues. These are all things that we need to think about. And then when we look at that future planning, we want to understand what our occupancy potentially could be, and then at what point do we break? Because we may have an extensive number of staff, but the staff can only work in that environment at that pace. We're in full PPE for 12 hours a day for a certain period of time before there's burnout. And so, again, as we look towards the future, we need to very, very carefully monitor our colleagues and our friends and make sure that we look for signs of PTSD. We need to make sure that we're, providing some type of support mechanism to ensure that these people have the right outlets. From a treatment standpoint, we do have the first emergency use authorization. from remdesivir. We'll continue to see more of these. There are lots and lots and lots of clinical studies going on right now around the world. Frankly, if we can get to a treatment option and a good vaccine, we're in a very good place to defeat this. If we only get to a treatment option, that certainly does not alleviate people still getting infection, whereas the vaccine does. So the ideal situation for us in the future, hopefully by the end of this year, would be have both a treatment therapeutic option as well as a vaccine. And then lastly, there's some risk management tools. This one is from the World Health Organization that actually looks at how do we manage exposure risk for healthcare providers in a very detailed and scientific manner. So I provided the web link there, and Judy's uploaded the actual PDF into the handouts. This is a great tool if you're in management to say, I need to make sure that we're managing your occupational risk carefully, and then we're using your skill set appropriately, because healthcare workers are critical infrastructure. And so if you're exposed and you're asymptomatic, then you can continue to work according to the current guidelines. This is something that we have to be prepared for, both from an infection prevention standpoint as well as a management standpoint as well. And those of you that are unfortunately playing mom, dad, and chief chef as well as teacher, you understand this sort of Oprah graphic here. But we want to look forward into how do we ensure that our healthcare system and our communities are prepared for things like this in the future. It's not just about everybody gets the opportunity to homeschool. It's really about everybody gets the opportunity to prepare in the future, and we need to make sure our families are ready for a pandemic so that we as healthcare workers can deliver upon that promise. So in conclusion, what are we looking like for the new normal? These are my sort of interpretations of leading the tea leaves, so take it for what it's worth. But I absolutely think, especially in certain hotspots, we'll continue to see social distancing. It is an effective tool. It's a pain, don't get me wrong, and it's going to be a very big pain for businesses, especially restaurants and other places, but it does help reduce that risk. We also want to be very, very vigilant in looking at our public health data, looking specifically at our ER data, what patients are coming into urgent cares with in their primary care offices to look for additional waves. One of the biggest problematic things that could happen would be we get hit with another wave in respiratory season, which we already have lots of challenges. And getting vaccines is another huge thing that hasn't been talked about a lot, but it is certainly a needed aspect of this conversation, because getting an influenza vaccine is going to provide protection against influenza as well as some other health conditions. Pneumonia shot is another perfect example. And as we add the COVID shot, we want to make sure people feel very safe receiving this vaccine. And, if you think about the pneumonia shot or the influenza shot, they've been around for years. So there's lots of safety data out there. There's lots of years of history. This is not going to be the same thing. So there's going to be a lot of skepticism, I would imagine, with people that are already vaccine hesitant, as we call it. And increased levels of personal protective equipment with a focus on eye protection. Again, goggles, some type of face shield is good. Certainly if you have any type of safety glasses, these are all things that we need to think about. And I see all too often patients walking into rooms where they're, following respiratory droplet precautions or something like that, but they're not wearing eye protection. And so eye protection is another aspect of the scenario that we need to include here. And then more broadly, testing of fit respirators for fit testing. And a respirator may not need to be in the form of something that's reusable or disposable. It could be a combination of both, where you have certain providers that are going to be issued a reusable device. For myself, I actually like my half-face respirator that I reuse. It's more comfortable. I get a perfect seal every single time for my face. You can actually even wear some of that with a little bit of facial hair, not a ton. So it does provide a little bit of an option. And there's some hospitals across the world that specialize in infectious diseases, and they don't use N95s. They actually give every single staff member a reusable respirator with the cartridges. They train them on it, and they're responsible for maintaining that for the duration of their employment. And that's a very sustainable strategy, because those cartridges can last for a lot longer than a reusable device that's being reprocessed. That's technically supposed to be disposable. And then lastly is the federal government and state governments have got to do a much better job of predicting the needs for the PPE stockpiles based on the data that we've learned from this pandemic. This was less scary as far as the consequence than Ebola, but it's had tremendous economic, political, socioeconomic, you name it, consequences, much different than what we had with Ebola. So that new normal is still going to be a moving target, but we recognize that vascular access professionals are going to be huge influencers because these patients are all going to need some form of vascular access. We can drive our decisions based on data, not on emotion. There's a lot of emotion running high, and I totally get it, but we need to base our decisions based on data. That data is going to help us predict for the future and plan accordingly. And we want to, again, hardwire our infection prevention and control practices. And that needs to be done in collaboration with our IPs. And then lastly is invest in your team, yourself, and your processes so that as we get hit with stuff like this in the future, which we will, it may not be COVID, but it will be something else. We want to make sure that we're prepared and ready for those types of things. As a reminder, the CDC website has got updated information on a daily basis. They make several updates throughout the day, including the weekends, and so you can always go there as well. The references are included here as well as the web links that were on the bottom of the slide. And as we sort of get ready for the Q&A, every single person that works in healthcare is in this together. I have seen some of the absolute best in this country come out through this pandemic. We've seen public safety collaboration. We've seen public health collaboration. We've seen people that are facilitating conversations with loved ones, where the nurse is essentially serving not as just the nurse, but the priest, the minister, the family member, the wife, the husband, as that person takes their last breath. And so we have certainly seen the absolute best that we have to offer. As Judy mentioned, we've got another webinar that's this Wednesday. This is designed for family members and people that are of the lay profession that are not healthcare providers, just to have a sort of a sense of basic questions, what is really recommended as well. And then when we look in the future, we recognize that the best of this country and the best of our healthcare profession can be done and designed under pressure. And so when we think about this quote, it really has a lot of meaning to me because we only grow in times of adversity, and we grow the fastest when we are up against, a very futile cause. But we recognize that with us as a collaborative healthcare entity, as vascular access professionals, as infection preventionists, as healthcare leaders and consumers of healthcare, together we can make sure that we move this forward. So with that, I'll stop and see what questions there are. This is my contact information in case you've got some personal questions that you want to ask. But Judy and Blake, I'll turn it back over to you for Q&A.
Thanks, Hudson. That was great. Really enjoyed it. Learned a lot, as always. So our first question comes from B. Entering a COVID room, I would want to wear an N95/an 1860 to protect myself. Am I not right to do so, although the floor staff are only wearing a surgical mask?
So I'm assuming that you're referring to going in to do a vascular access procedure?
She's a vascular access specialist, so yes.
Yeah, so if you are going to have reasonable suspicion to come in contact with aerosols, then you would absolutely be, indicated to wear an N95 mask. If you are going patient to patient with high-risk patients, then, it's really an institutional and a personal decision. Again, if it was me and it was my health and wellness, given what we know about this virus, and I had access to an N95, then I would certainly wear an N95. That's just my own recommendation. But, that's something that I would consider. I've had this happen to me where I've gone into a hospital to get a critical care patient who were taken to a high level of care. I come in wearing a full respirator, face shield, and staff is wearing none of that. And I just explained to them that, what your facility does is what your facility does, but what my practice is going to be is to provide myself the highest level of protection that I have access to. So I don't think there's anything wrong at all with the vascular access specialist walking into a room with a respirator if they have one.
Let's put that scenario a little different. What if they're going room to room? They've already placed devices and they're looking at the device itself. They're doing line care, or they're even just doing an audit.
Mm-hmm.
N95, if they have it?
I mean, again, if you have it, there's no reason you can't use it.
Okay.
What we're finding is that many hospitals are sort of dialing back the use of an N95 in general. So if your hospital is saying that those respirators are only reserved for people that are doing procedures that generate aerosols, then that's what you really need to try to stick with. But if you've got access to an N95, there's no harm in that as well. It's certainly not going to be harmful other than the fact that you need to be fit tested for it, preferably. You need to be making sure it's maintained well. It needs to be reprocessed, because what we find with any mask is that the outside of that mask is highly contaminated with pathogen, not just viral particles, but other stuff that's in the healthcare environment. So wearing a mask is not an end-all be-all, and it's not curative of the problem, especially if we don't remove it properly. For myself, I actually, sounds kind of stupid, but I use a Tupperware container that's a square one, and I actually put the mask face down so that I've got the part that goes to my face up. I put it down in the Tupperware, I put the lid back on, and I pull the straps around that. So every time that I go to put my mask back on, I'm holding the Tupperware and I'm not holding the mask. So there's little caveats that you can try that will help reduce that risk. You can't do that with a surgical mask, of course. But, if you're being asked to wear the same surgical mask all day long, that's not working. So, I would encourage you, if you have access to an N95, it's certainly fine to use that as long as your hospital doesn't prohibit it.
Thank you. Our hospital system just changed the PPE requirement to only need a surgical mask and face shield for COVID patients, and are not supplying N95s for us. They are also not allowing us to wear N95s from home. This is because the crisis supply shortage provided by the CDC. Is it safe to wear only surgical mask and face shield when providing direct care in COVID patient rooms? Or is an N95 only required when there are aerosolized treatments?
So again, I go back to availability. So if the hospital is rationing N95s for aerosol-generating procedures, then they are directly in alignment with what CDC is saying. They are following CDC guidelines. If you are a patient, yourself, for example, and you have a lot of chronic respiratory issues, or if you're going to be going down to the OR to insert something and there's going to be aerosols, then you would certainly be at high risk. But general use of a surgical mask with a face shield, I don't have any problems with at all. And I think I'm glad you used the word face shield. A face shield is highly, highly, highly effective. So if you can get your hands on a disposable face shield and reuse it and clean it, then that is very, very effective, and that's going to help reduce any risk, and that's going to minimize the need for N95s. We're not finding that this is a traditional airborne virus. It's much more of a respiratory droplet. But, with aerosols, there's a high possibility of having lots and lots of viral particles in the air. So, but you could safely care if you're wearing a surgical mask and face shield.
What type of goggles are best with COVID patients? Indirect vent?
So it depends on what you're wearing them with. So if you're wearing a face shield over that, most goggles will work fine. The biggest thing is to make sure that they properly fit your face and they are going to be anti-fog. If you don't have anti-fog, you're going to run into issues. But I've seen many, many out there. 3M makes a whole bunch of them. They're probably the biggest area in this. There's many that you can find online that meet that. You do want to make sure that they're fog resistant, though. And then if you have a strap on them, you need to figure out a way to be able to clean that. What I personally do is I actually take a 80% alcohol liquid that I have, and I have a little tiny squirt bottle, and I spray down the strap of my goggles, and that works very effectively, because you can't really put bleach and some of the other traditional disinfectants on that, because it'll degrade it.
What are your thoughts on hair coverings, personal ones and bouffants for sterile procedures, wearing continuously with COVID patients? Question mark.
So if you're going to do a procedure, I would recommend changing it between patients. If you're just going to be working on the floor, and if it's only a COVID floor, then it's fine to wear the same bouffant cap all day. I'm totally cool with that. I think, again, we want to be rational and not overreact to this, because, what does the bouffant cap actually do? Let's just be real for a second. Does it really protect the patient? Probably not. Does it provide some level of protection for us? Probably a little bit. The same is true with surgical shoe covers. These are not impervious things. It's not like nothing can get through there, especially a liquid. So let's be realistic with what our expectation is. It's good to cover our clothing. It's good to cover our hair if we're going to be working in these wards on a daily basis. For myself, if I'm going between patients, I change the hairnet every single time. There are also technologies like UV lights that can disinfect them as well. So there are other options if you don't have access to it. But I very rarely have heard that people are having issues getting these types of supplies. It's usually like the gowns and stuff like that.
When do you foresee general antibody testing for the general public?
That's a great question. I ask myself, what's the utility of that? And if I know, and let's sort of start a little bit backwards and start with active infection. So does it make sense to test every single American for infection? In my mind, absolutely not. It's not going to change what I'm going to do with them. It's not going to change my treatment or anything like that. So that's really just a point of time of an epidemiology perspective. Antibody testing, on the other hand, will hopefully tell us how many people have been exposed. But the missing answer in sort of this equation is, what does that mean? If I have so many antibodies, does that mean I'm actually immune to the virus? And we don't know that yet. So yes, it's a great test to have. It's good to know how many people are exposed. Those are all public health interventions. But from a medical perspective, it's not going to tell me, yes, this person's immune. And I think as we get further along with the vaccine trials, we'll have a better idea of what immunity looks like and for how long. Is this going to be a vaccine that's updated annually like the flu shot, or is this going to be something that's going to have a little bit more long-term impact in the immune system? And those are all unanswered questions. So I wouldn't recommend right now generalized antibody testing until we understand the impacts, because if I'm the patient, you say you have antibodies, my next question is going to be, am I immune? And if I can't answer that as your healthcare provider, I really think that's a mistake for our patients. So it's a good thing to have, but we need to use it judiciously and for the right reasons.
Thank you. Do you think scheduled conferences such as AVA in September will happen? Crystal ball.
Oh,
there you
I
go.
wish you had asked at a different conference, since the director of AVA Education is on the phone. I mean, I think that's up in the air, to be honest with you. Is it absolutely necessary to cancel conferences? I don't think we can answer that right now. And, given that people are on very tight budgets and hospitals are financially strained, I personally don't foresee a lot of in-person conferences for the remainder of 2020. I was slated to attend about 8, and they all canceled. Several of them were in the September-October timeframe, so I think that'll be a decision. I know AVA sent out a very proactive survey to sort of understand where the membership is coming from, but right now I think that's very up in the air.
Can you explain the different levels of gowns?
Yes, so there's different ANSI ratings. There's 1, 2, 3, and 4. When you think about level 1, that's your traditional isolation gown, your very, very basic, that has the lowest level of protection. Level 2 is going to go above that. And really, there's not a recommendation for COVID infection that it has to be impervious, because there's not this massive risk of body fluid contamination like there was with Ebola virus disease. But a level 1 or a level 2 would be fine. What I would caution us on is that many of the gowns that hospitals are getting right now are not rated at all. And so that's something that you should think about and speak to your materials manager. When you get the gowns, many of them actually have the rating inside of the gown or on the package, so you can look for that pretty easily. But it is important that we're using isolation gear that is appropriately rated for use in healthcare and will provide the appropriate level of protection, because level 3 and 4 is what we typically see in sterile procedures and surgery and stuff like that. So what you get in your PICC insertion kit, for example, is going to be a sterile procedural gown, which that's not necessary for take care of COVID patients.
My facility is now saying regular surgical mask is adequate for COVID positive patients, since the N95s are almost depleted. Does the CDC guide this recommendation?
So the CDC has 3 categories of recommendations for PPE. Sort of, there's status quo, normal practices. The next is, hey, we're starting to see a problem. And the third is what I call the oh crap, which is what we're in right now, because we have no specific recommendations that are guided by what we've seen in the past. So, they're operating sort of a little bit in the blind with this. And the stage that we're at right now, it is acceptable to arm staff with a regular surgical mask unless it's an aerosol-generating procedure. So if your facility is having very minimal interruptions with PPE, then that's when you could start to be a little bit more lenient with your N95 respirators. But right now, we're not in that conventional strategy at all. So it's a very problematic stage for us to be. And again, that mask needs to preferably not be worn the entire shift. I think that's really important that we stress that those masks were never designed to be worn all day, especially we're not even fully in summer yet. When it gets hot and humid, especially where I live, you're not going to survive wearing that mask because you're going to be sweating through that membrane that's protective.
Do you think, I mean, if we had proper PPE, if we had N95s for all, would CDC have made that recommendation, in your opinion? Would they be calling for N95s during this crisis?
Well, the general recommendation initially was to wear an N95. So, again, if you're looking at where we are, it specifically says if you are not having PPE shortages, an N95 would be fine.
Okay.
And if you don't have PPE, which is where we are in many cases right now, then a surgical mask. So we're absolutely saying that that is a lower level of protection. That is what's recommended. But we're in a sort of a shortage piece, and that's why I really strongly recommend for those of us on the line that you speak to your administrative staff about getting reusable respirator masks and assigning them to your team. That is a much more sustainable strategy. It's more comfortable. They can keep up with it themselves, and you're not going to run out. Financially, it's $45 to $60 per mask. It's not a big deal when you think about that, and it gives you a lot more control because you're not relying upon disposable products. You're relying upon yourself to have access to that mask, and I think that's a lot more sustainable.
Yeah, and I know we've had questions about can you wear a PAPR or capper in sterile procedures, and there are many that have the fan pointing backwards. So they're
we're not and we're not in a normal time. So what we would normally do as our traditional standard of care may slightly differ. And what we don't want to do is put our patients at risk. So if we think that what we're going to do is putting patients at risk, then we don't want to go down that pathway. But if we can do it with a reasonable level of safety, then I think it's very appropriate. But again, we need to operate in the instances that we're in with the cards that we're dealt and make sure that we're keeping ourselves safe. Because I had many people after the last webinar email me and said, my employer will not provide me PPE and is telling me to still deliver care. And that is grossly unacceptable. That is, in my mind, malpractice, asking a healthcare worker to go into a known infectious room with no protection at all. So a surgical mask is not the absolute ideal, but it is protection. So that's much different than sending someone in there without the appropriate PPE at all.
Do you have recommendation for ultrasound use room to room with COVID? Any different considerations for disinfecting? I know we feel this one almost every webinar, so I like that it keeps coming up because we need to use ultrasound.
Yeah, we certainly don't want to subtract away from standard of care. This is honestly no different than anything else. I am not a huge proponent of, spending a ton of money on covers when you can easily disinfect it. So my only caveat to saying that is that if you have an older piece of equipment with lots of moving parts and pieces and you can't disinfect it easily, then a cover might be helpful. But a cover alone doesn't negate the fact that you still have to disinfect it. So it's only another layer of protection similar to PPE. So I would honestly not waste any money on that. I would, pull it out, closest to the door, go ahead and disinfect it, and then you could disinfect it again when you get outside if you needed to. But this virus is very, very easy to kill on surfaces, so you should have no issues doing that.
Have you seen many COVID positive patients with only GI symptoms?
I have. I've seen two. That was their only presentation was diarrhea and nausea, but not a ton. But I have seen two.
What are your thoughts on reusable respirators, and how often would you change the filters?
So I think I've said a couple times on purpose that I'm a big proponent of reusable respirators because they reduce our sort of requirement and dependency upon those disposable products. And the filters themselves, if you're looking at a traditional particulate filter, the manufacturer will give you guidance on that that's per their testing. And you can clean those filters as well following the manufacturer's instructions. There are ways to do that varies by the manufacturer. And these are devices that the mask itself will last for long periods of time, and it can be issued to you as an employee. So if I'm a vascular access team and I'm thinking about, hey, what do I do to prepare my team for safety in the future? I would start there personally. And some of those are very easy to get right now because they're making them up a storm. Others are not, but there's several different ones that are out there. It still allows you to wear your face shield. You can still wear eye protection if you want to. there's no issue with that. But I think that's a very sustainable solution to do, and the filter change will depend upon what the manufacturer guides you to do.
Perfect. In our ER, we are using a secondary triage room to screen triage acuity 5 patients who just need to be tested. They're screenings in the triage room, and they're screened in the triage room and then swabbed outside of the ER. The nurse who is screening is walking out with them through the ER in their PPE. They were wearing in the room itself when swabbing them. What are your thoughts on that practice?
So the gold solution here would be to triage them outside of the physical doors. So what a lot of hospitals are doing, especially here in Atlanta, is they put up tents outside where that screening and triage is taking place prior to entry into the primary ER. So that would be best practice. If that person is wearing personal protective equipment and then going into a waiting room where there are, likely people that are coming in for other things, it's not best practice. It sounds more like a logistical question to me of trying to make sure you have the right flow of patients. But the best practice would be not to bring these people into the building until they've been screened. So if you're coming into an emergency department, there should be some person outside that's screening you prior to you even entering the doors. Because once they get in the hospital, they got carte blanche as to where they might potentially go. So I would try to recommend that we don't be walking through everywhere with PPE. If we can help it. That being said, you're going to have specific scenarios, and this has happened to me, where you're going to have patients that are being either transferred or discharged from traditional floors. And many hospitals have locked down the areas where you can only go in and out of the emergency department for security purposes. And it is very appropriate for EMS providers or critical care transport to wear PPE as long as they're guided by a clean staff member. And so that's really a best practice because there's many things that, EMS and critical care may be doing en route from one place to another until they get to their truck. That could put them at risk, like suctioning or bagging the patient or having to do something with the cardiac monitor or move the patient, whatever it may be. So there will be some exceptions to that rule as well.
Is it safe to reuse my own N95 after it's aired / under the sun for a couple of days?
Generally, yeah, that would be fine. I mean, UV radiation is very effective at killing viral particles in general. I would be more worried about if you were like me and had allergies and you had allergens now in that mask. So, certainly the best practice would be is to have that reprocessed at your facility using an established reprocessing technique like vaporized hydrogen peroxide or sterilization or something like that that was validated for that mask. Some of the big companies have put out guidance about what they have tested so far in order to do that. But, UV radiation is very effective at killing this. It doesn't even take several days. It just takes, an hour or so.
What's your opinion of using the same PPE while attending multiple COVID-19 patients on the same unit?
So again, I go back to the same questions that we asked earlier or same statements that I made about conventional versus crisis strategy. If you're in a facility that is very limited on the amount of PPE, then the staff should be dedicated to that COVID unit and they should have dedicated PPE. There's really no reason other than what we would normally do, of course, is not rewear PPE between patients. But in this circumstance, that would be an acceptable practice because we're in crisis mode right now. But again, it would need to be between only COVID patients and only in an isolated area. So you couldn't go through the hospital and go from a COVID patient on the 7th floor to a COVID patient on the 5th floor and wear the same PPE. That would not be recommended.
An outpatient procedure for a PIC due to chemo or IV antibiotics. Should I treat that patient as a rule out or under investigation and have them wear a mask coming in and ask prelim questions the night before to rule out COVID?
That's a great question. So right now, my general recommendation would be to treat everybody as potentially infectious and screen them as such. So again, are you febrile? Do you have any of the following symptoms? Have you been exposed to anyone with known or suspected COVID? Have you been outside of your community? Have you been outside the United States? If they answer negative to all of those, they're asymptomatic, they're afebrile, it still would be absolutely recommended to have them wear just a regular mask. And that could be a mask they bring in. That doesn't have to be a mask we give them. But what we don't want to do, and this has been an unfortunate consequence, is we cannot stop our basic medical procedures for these patients, especially our oncology patients that desperately need help. There's people that have been waiting for oncology surgeries for 2 months because surgeries have not been open for the most part. And so we really need to get back to some sense of normalcy, but also make sure we take the basic infection prevention measures that we can protect ourselves as our patients. And I think that's a very reasonable compromise.
Are they still requesting those who have confirmed antibodies to donate plasma as a treatment modality, possibly?
Yes, they are. I know the American Red Cross and other blood banks have been requesting this specifically. So if you know someone, or unfortunately if you were one of those people, then absolutely there's a lot of utility and value in that plasma donation. Some of that is also being used for research purposes as well to determine, what if is sort of the natural load that we need for antibodies to determine some type of immunity, either for long-term immunity, short-term immunity, or for therapeutic treatment options.
This is a question we've talked about a couple times, and I've heard this in my own personal experience. Upon admit from the ED, a COVID patient under investigation, the patient's admitted, they tested negative. How often, and they still have symptoms, do you keep them on precautions?
That's probably one of the best questions I've heard. The answer is yes, you keep them on precautions. So if that patient is symptomatic, I don't care what the laboratory result tells you, you treat them as if they're symptomatic, and continue to treat them as under investigation. And the reason being is that you could absolutely test negative today at 3:26 Eastern time. You could test negative right now, and at 5 o'clock you could test positive, depending upon where the virus was in its sort of life cycle and incubation period. So if you are, sort of clinically seeing symptoms and that symptomology is appropriate, then you absolutely keep them on the precautions until you rule out otherwise. Now, if they come back as they've got a pneumonia or something like that, then that's another conversation you can have. But there's not a hard and fast that you need to keep testing them every single day per se. But it would certainly be worthwhile to test them periodically throughout their hospitalization, and that would be. I know the Infectious Disease Society of America has put out some limited guidelines about that topic as well, so I'd be happy to share those with whoever asks that question.
I think that'd be great, because we hear about that a lot. And what's the rate of false negatives on these? Do we know?
So with the test itself, if it's the PCR test, it's highly, highly, highly accurate, upwards of 90%, well above that. The antigen test that has just come out, as I mentioned before, is only about 85% confirmatory for patients that truly have this. So there is that 15% window, and that's why, let's say that you have somebody that presents to you in the outpatient world, and they need a PEC or something like that, and their COVID test, their antigen test was negative in the office, but they're symptomatic. That doesn't matter. I'm going to confirm that test with the PCR methodology to rule out any of those false negatives that might take place. So, my sort of hard and fast rule with this is that the patient in front of you is symptomatic. Don't worry about what the lab test says. Treat them as if they're symptomatic until you prove otherwise. We can't take, a chance in not protecting ourselves, because as healthcare workers, your multiplying force of your expertise, especially in vascular access, is tremendous. So we can't afford to bench it by having an exposure that was completely unnecessary.
Well, I understand it makes no sense to test everyone. Shouldn't people that work in areas where there's close contact with others be tested daily once testing is easily available?
So I think that's a really reasonable question, but again, the utility of that is pretty low, because you could test negative when you come in at 7 a.m. and you could test positive at 5 p.m. in the middle of your shift. So, healthcare workers, especially those that are symptomatic, are absolutely of the highest value as far as testing. For example, I know the governor of New York has made a recommendation now, actually a requirement, I believe, that nursing home staff have to be tested twice in a week. I have no idea where he came up with that. I don't know any science behind that. So I would be much more interested in doing the screening questionnaire, the temperature checking, making sure all of those things were in line, than I would do daily testing. I'm not saying that may not change in the future, but right now that's probably not the best usage of the test that we have available to us. Now, what would be very interesting to that question is, as we get more specifics on the utility of the antibody testing, that would be something that would be hugely helpful to test all healthcare workers, because if I'm the chief nursing executive, for example, and I get data back that says 83% of my staff are immune, that's huge, right? Versus if I only have 13% of my staff. And I think that's going to be more of the wave of the future once we understand what is truly immune and what is not.
When we get a vaccine, do you think it'll be effective as in hepatitis vaccine, or do you anticipate it being more like a flu vaccine that's annual?
I am not a vaccine expert nor a virologist, but from what I have been told by my colleagues at CDC, they are most likely anticipating that this will be an annual vaccine. That is what all indications are pointing towards currently. I'm not saying that that's what they'll yield with at the end result, but again, there's many countries working on a vaccine. But I fully anticipate this will be an annual vaccine similar to a flu shot. And there's even a possibility it could be combined with a flu shot. We don't know until the vaccine work and the efficacy studies and safety studies are completed as to what that final commercial product will look like.
Very good. Follow up to that, do you know about COVID mutations thus far?
There are some limited data that have indicated that there's mutations. Whether or not those will impact the efficacy of the vaccine is yet to be understood, but there's essentially two basic forms of the COVID-19, or should I say the coronavirus itself that caused COVID-19. Slight genetic mutations are very normal for viruses, so that's not something that's abnormal or that wouldn't be expected. Right now, it's nowhere near what like the flu is, where we have sort of that shift, but it's not to say that it couldn't get there. So there's a lot of sort of unanswered questions in that realm right now. But right now, genetic mutation is not causing a huge issue. Again, we don't have widespread therapeutics or vaccines available, so it'll be interesting to see what the virologists and the vaccine experts come up with related to that.
One of our manufacturing partners is hearing that hospitals may require weekly testing prior to entering the facility. One, is it realistic, and would it be reliable?
I frankly think that's a complete waste of time, money, and resources. There's really no reason to do that. Again, if I test you on Monday and you're a vendor rep coming in to help with a procedure, I'm thinking a lot of folks that go into the OR to help the surgeons. If I'm negative Monday and I don't get retested again to the following Monday, I could test positive Tuesday, Wednesday, Thursday, Friday, and no one would ever know. So the best strategy to protect ourselves as the healthcare team and the patient is to make sure that all of our vendors and all of our staff are wearing respiratory protection, washing their hands, following our infection control guidelines. There's really no reason or any science to support that.
Our facilities are requiring all people entering the hospital to wear a surgical mask at all times, except during eating or going to the restroom. We are required to wear these masks for 3 shifts before obtaining a new one. Thoughts?
My thought is scary. Surgical masks don't last that long. So wearing them for 3 12-hour shifts is not going to be efficacious. I can't think of one manufacturer that I'm familiar with that will support efficacy for that, even in crisis situations. So, absolute best practice would be to, wear several masks throughout the day if you have that ability. Worst case would be to, throw your mask away at the end of the shift. Again, I go back to the face shield. This is something that can be very helpful for us because it's not just protection from them giving us the virus, but it's also protection from us giving anyone else the virus. So that face shield is very, very helpful, and it's a very inexpensive sort of add to our PPE collection that we could get. I know for myself, I have reusable face shields that have my name on them, and I can easily disinfect those, and I've used those for well over 200 patients with no issues, and they're very inexpensive. You can even buy them at Lowe's and places like that. So I would recommend that you think about that as well.
So a couple more mask questions. I think there's a lot of confusion and a lot of worry with this. So we're saying, is it okay to wear one N95 if going to several patients? And also a follow-up with that is, what do you think about putting a mask over that N95? I'm going to leave it at that.
So if you're wearing the same N95 to go between patients, I don't really have a tremendous amount of concerns with that. It's a respirator mask. It's not going to come in contact with the patient. That's a very low thing on the totem pole in my brain. Again, if you're wearing a face shield, it's even more protective for you as well. And then what was the second part of the question, Judy?
It's wearing a disposable surgical mask over the N95 and tossing that one between patients.
That would be fine. There's nothing saying you have to do that, but that would be fine as well. I know a lot of people are wearing cloth masks and stuff over that. The biggest risk is I'm actually less worried about the respirator or the mask causing contamination to the patient. I'm more worried about it causing contamination to us. So, when we're touching those masks, immediately after we remove it, we need to wash our hands or use alcohol-based hand sanitizer because those masks will get easily contaminated.
So this one is about changing out an asymptomatic line to a PIC in less than a week. And we've talked about this a few times. We talked about it at Coffee Talk. First of all, if it was emergent, did it go up in the groin? Did it go in the inguinal crease? That's more likely to be infected. Did you put it down lower? But I mean, changing out an asymptomatic line after a week, hopefully we could put it in a better spot down the leg a little bit. Hudson, your thoughts on that?
Yeah, I would agree. And I think the same goes true for peripheral IVs, especially, or EJs or something like that are placed in the pre-hospital setting. The general recommendation is, we don't need to treat everything as if it's infected just because of where it is. We need to, especially for some of the patients that I've seen that are high-risk dialysis patients with very limited access. I think every patient's vasculature warrants, sort of an approach to preservation from that perspective. So every patient might be a little bit different.
I agree. It shouldn't be a policy to change out a line because it's on a day.
I agree. I totally agree. Yeah, I mean, if I've got a patent, I'm thinking about a kid especially. That's like the worst nightmare of me is sticking a kid. Right. And if I get a line in them, I don't want to move it unless it's not patent anymore or it's infected or something like that. So I think we need to look at how do we maintain the integrity of the device, the patency of it, but also think about the patient too.
And going back to another topic, if it's emergent, put an IO in until you can put one in pretty. IOs are a perfect bridge.
Yeah, I like IOs a lot. I think they're underutilized, and many emergency departments, when we bring patients in with them, are trying to immediately rip them out versus realizing there's a lot of utility with those, and they allow for large volume resuscitation, and some of these patients really need that. So again, we need to think about that overall vessel preservation and status of those patients before we rip stuff out.
The isolation gown is hung outside of a COVID patient room so the medical staff can share. What's your thoughts?
I see that all the time. And, again, what I would normally say is different than what I will say now. In a normal setting, Hudson would say, no, don't do that. Throw it away. It's disposable. In the world that we're in today, until we get a better handle on PPE, then that is a practice that you're going to continue to see. The question is how long should I leave that gown up there? And again, best practice recommendation would be to not reuse gowns. That's not where we are today. The next sort of recommendation would be to throw it away, at the end of each day. That would be good. But we certainly don't want to see those things hanging there for days and days and days because they will, absorb viral particles.
A reusable respirator manufacturer does not provide recommendations to changing the filters. Where should we obtain that information?
You should change mask. That's anytime a manufacturer is not providing you with adequate instructions for use, you're using the wrong product. So not to bash on a particular product or anything, but you want to make sure that you have good indications of when something as important as cartridges should be changed out. If you're not finding that information and you want to check, you're welcome to email me and I'll look it up for you in my system and see if I've got access to it. But most manufacturers do provide that information.
What do you use to disinfect the face shield?
I use a regular EPA registered disinfectant. So the only thing that I would not recommend is a sodium hypochlorite or bleach solution for a lot of different reasons. You don't want to have that type of vapor near your mucosal membranes, obviously, and it can degrade it. But a regular quaternary ammonium, alcohol solution, hydrogen peroxide, those are all fine. And you might see some level of smearing. I personally use a quat and alcohol combination when I disinfect mine, and that way I don't have a lot of smearing, but you can always wait for the contact time and then just take a wet paper towel and wipe away any smearing after the contact time has been achieved.
Perfect. Georgia has seen a decrease in positive cases since reopening. which is great. Do you believe the warm weather / increased humidity played a factor?
No, I don't. I mean, while viral particles are very easily inactivated by sun and UV radiation, that's not something. There's been multiple studies that have looked at this. That's not. I mean, we can't, unless we put every single patient or person under investigation out in the sun in the front lawn. It's not going to do anything to the internal body. It's really good and effective at killing things on the outside, like environmental surfaces, phones, stethoscopes, stuff like that. But it's not going to do anything to the patient's internal system where the virus is actually replicating. So it's great for the environment, but not necessarily helpful for the patient.
So Vicki has a question for us. Her 81-year-old aunt, who was COVID positive and then has 2 negative tests, was moved to rehab. Why won't they let her, or, hold on, there's follow-up to it, or anyone who have previously tested positive take a shower? They only use body wipes.
So there's no reason that she shouldn't be able to take a shower. I'm not sure if that's a logistical thing. So, if someone is asymptomatic and has 2 consecutive negative tests, then they are deemed clear of the virus. But there is certainly that potential for reinfection, which is most likely where this concern is coming from at the nursing home. But there's no reason at all that a patient should not be afforded a shower. At all. Again, the virus is very easily killed. Now, certainly if you're, having some type of steam, you're going to have aerosol, stuff like that. But again, if the person's asymptomatic, 2 negative tests, they're very low, very less likely to have any situation from that perspective. So there's no reason they should be not getting a shower. That's just flat out gross, to say the least. And I feel horrible for that patient.
The whole facility. I feel bad for the folks working there as well, because that can't be good for anyone. So I think really we've come up for all the questions. Any parting wisdom you want to share with our group that's still hanging in there?
I see one question that I think is probably a good place to close, and the question is very simple. Will we overcome this and when? The answer to the first part is yes. I have no doubt that we will overcome this globally, and specifically in the U.S. I have great confidence in our healthcare system. Will we emerge without scars? Probably not. And I think sometimes those scars are important for us to recognize where we were and where we need to go. We need to put a lot more focus on infection prevention. We need to put a lot more focus on protecting our healthcare teams. We need to put a lot more focus on resiliency and healthcare training and cross-training. Vascular access has lots of utility in ICU, the emergency department, pre-hospital settings, critical care. We need to think differently is probably the best thing that I can say. But I absolutely have complete optimism that we will overcome this. How long that will take, I don't know. I think this is something that we will be battling through the end of the year, and specifically through when we have a vaccine. When we have a vaccine, we then have the next fight of getting people to get the vaccine and thinking that it's safe enough to get. So this road is not yet over, and we're sort of paving the highway as we go in many instances, but I have great confidence in our ability to overcome it.
Hudson, I can't thank you enough for another great webinar. I appreciate your time and your expertise. Folks, I appreciate all of you as well for hanging in there, staying with us till the end. I hope you'll be at our next webinar, and stay safe out there. Thanks so much. See you next time.